Hi, everyone. Welcome. Hi, Jane. Welcome to the ICA's monthly speaker series, Navigating IC BPS Conversations with Experts. We are delighted that you are here with us today to learn about IC BPS and chronic overlapping pain conditions from Chris Veasley, co-founder and director of the Chronic Pain Research Alliance. Please note that this session will be recorded. If you are on camera, your video will be included in the recording. We will have a Q&A session following the presentation. To ask a general question related to this topic throughout the session, please use the chat feature. Once the Q&A session has started, you may also use the raise hand feature in Zoom. You will be asked to unmute yourself. If you aren't speaking, please be sure to stay muted. Chris will answer as many questions as she can during the webinar. And finally, please complete the post-webinar survey. A link to the survey has been posted in the chat. It's time to get started. Without further ado, please welcome Chris Veasley.
Thank you so much. It's a pleasure to join everyone today. I'm going to share my screen. All right, can you see my slides?
Yes, we can see them.
Awesome. So my name is Chris Veasley. I'm the co-founder and director of the Chronic Pain Research Alliance. We are an advocacy initiative that's part of the TMJ Association. And really our goal centers around advocating for high-level research funding on chronic overlapping pain conditions, which I'm going to get into in a few minutes. We also work in the area of knowledge translation, so we want to make sure that new research findings that are being published are getting out into the hands of clinicians and people who lived with these conditions so they can make better informed decisions about their healthcare. And then we also advocate for a holistic team-based model treatment approach for people who have chronic overlapping pain conditions and work in the R&D or research and development space to advance therapeutics. I myself have a 30-year lived experience with chronic pain. I was hit by a car when I was 15 years old and survived that accident and ended up developing a number of chronic overlapping pain conditions over the years, starting at age 17, 18. I have a background in research, spent a few years doing basic and clinical neuroscience research at Johns Hopkins. I was the former director of the National Vulvodynia Association and have partnered with the ICA in many capacities over the years. Right now, I advise on about a dozen academic studies that are funded across the United States by PCORI, the National Institutes of Health, the FDA, CDC, and the DoD. And I'm also serving on a number of federal committees related to advancing research initiatives for chronic overlapping pain conditions and chronic pain in general. So I'm going to get started, and today just talking just generally about what chronic overlapping pain conditions are, how they relate to IC, what the research has shown us, and kind of how we're translating that into improved care for people with these conditions. So what are chronic overlapping pain conditions, or COPCs, as we call them? This term, through our advocacy and also advocacy by the Interstitial Cystitis Association with us back around 2010, 2011, we started advocating for a term to be applied to these conditions. And the NIH and Congress adopted a term around 2013 of chronic overlapping pain conditions. It's a term that's used to describe conditions that often coexist and share similar disease mechanisms across the neurologic, endocrine, and immune system. They include the conditions that you're seeing on your screen in the Venn diagram. And these conditions predominantly or solely affect women. Any number and combination of these conditions is possible. Several conditions can develop at once or gradually over the years. And as research has advanced, we are now uncovering new associations. So it's not just that there's an overlap of these 10 conditions, but certainly with other chronic pain conditions as well. Something common in COPEs is also the fact that people have non-pain comorbidities and other contributing factors. So these include, sleep disturbance, mood disorders, cognitive impairment, sexual dysfunction, social dysfunction, and physical disability. As we all know, people who live with a variety of chronic pain conditions, pain in and of itself has far-reaching impact, can cause fatigue, impairment, cognitive impairment, and various degrees of physical, social, and sexual dysfunction. And then in addition to that, certain medications or treatments that we may be utilizing for chronic pain or how their other health conditions can also contribute, to that vicious cycle. So this interplay is unique to each individual person, and it's highly complex and needs to be treated as such. So we do advocate for a comprehensive assessment that includes evaluations of all of these conditions and all the factors that may be contributing to someone's chronic pain experience. So there's also this issue of complexity, right? So we know that America has become a nation of chronic disease. So chronic pain rarely exists by itself. We know that 6 in 10 adults in the United States have at least one chronic disease, and 4 in 10 have 2 or more. So these can include a host of different conditions like heart disease, cancer, stroke, Alzheimer's, diabetes, kidney disease, and many other. So the end experience and the complexity of this is highly individual for each person. So you have people who have multiple chronic conditions, including those that we just mentioned. On top of that, they can have multiple pain conditions or pain in different parts of their body. In addition to that, multiple non-pain related conditions like the sleep disturbance, cognitive impairment, mood disorders that we just talked about. And then on top of that, each of us is highly individual, right? So we have an individualized biopsychosocial spiritual experience and impact of chronic pain. So what have we learned about prevalence rates of chronic overlapping pain conditions? There have been a few major studies. The MAP, I'm sure you all are very aware of, which was a prominent longitudinal NIH-led IC study where comorbidity was assessed as an important disease modifier. Of the 424 participants, 38% reported at least one comorbid pain condition, and that was higher in women than men. And the rates included 8% for ME/CFS, 9% for fibromyalgia, 57% for irritable bowel, and importantly, 25% of people had more than one diagnosis. And in those who did have comorbidity, what they found is that those IC patients had more severe bladder symptoms. They had greater pain severity and interference in general, had increased rates of depression, anxiety, and stress, and increased disability and decreased quality of life. So the research team associated with MAP came up with 2 constructs that are highly associated with having interstitial cystitis and comorbidity, which they term generalized sensory sensitivity, which just simply means that people had increased sensitivity to external stimuli across multiple sensory modalities. So this could be touch, heat, cold, pressure, any of those things. They had increased sensitivity to internal symptoms, so just meaning they had heightened what people call somatic awareness, but it could have sensitivity to light, to sounds, to odors, just general body pain, and then increased hyperalgesia or allodynia in multiple body region, which just means they have abnormal pain processing in different areas of their body. The second construct they came up with, they called SPACE, which means that people who have IC and comorbid conditions presented with sleep disturbance. It stands for S. P stands for widespread pain, so just outside of the area of the bladder to other parts of the body. A stands for negative affect. They were more likely to have negative affect. C, cognitive dysfunction, and then E, energy depletion and fatigue. And these are things that have been shown in the literature for quite a number of years. So what do we know? This figure that I'm going to show you is from another longitudinal study called the OPERA study, which was mainly in people with temporomandibular disorders, that also looked at comorbidity rates, including interstitial cystitis. And what they found is that people who go on to develop chronic overlapping pain conditions have genetic variability. So they have genetic susceptibility to developing a host of different conditions. It's not just one gene that's impacted, but a host of different genes in the neurologic, endocrine, and immune system. And that combined with your individualized environmental exposure, put people at increased rates or prevalence of having mood disorders, heightened stress responses, increased somatic symptoms, sensory dysregulation, immunoinflammatory dysfunction, endocrine dysfunction, and autonomic dysregulation. And that all contributed to increasing levels of emotional distress and pain amplification, just meaning increased pain sensitivity or higher pain levels, which bidirectionally impact one another, which then leads to the development of chronic overlapping pain conditions, which first starts as subclinical signs and symptoms, and then can move up to transient states of COPE. So people could remit, they could have it for a while, have pain in a certain area of their body for a while, and goes away, comes back. And then those that gradually persist on to having persistent or continuous presence of chronic overlapping pain conditions. So I know this is a lot to take in, but the bottom line here is that it's complex. It's not just one gene. It's not just one environmental exposure. It's not just one body system, but a complex interplay between the neurologic, the immune, inflammatory, and the endocrine system that play a role in developing chronic overlapping pain conditions. So the OPERA study also looked at a cluster analysis. So as we know, not every single person that has IC is the same, right? Or not every single person that has temporomandibular disorders is the same. And patients tend to parse out into different subgroups or populations. So as I mentioned, the OPERA study was, again, like the MAP, a prominent NIH-funded longitudinal study. They did a cluster analysis of over 1,000 chronic TMD cases and over 3,000 controls who did not have temporomandibular disorders. And they found that patients typically divided into 3 different clusters. So cluster 1, they identified and labeled as adaptive. So these were people that had relatively normal psychosocial and autonomic profiles, normal muscle sensitivity. There were more men than women in this group, very few chronic TMD cases. The chronic TMD cases that were in this group were moderately symptomatic, very few overlapping conditions, and few negative life events. In the second cluster, they termed pain sensitive. Again, these folks had relatively normal psychosocial and autonomic profiles, but they had greater muscle pain sensitivity. There was about an equal number of male to female people that clustered into this group. There were an equal number of chronic TMD cases to non-cases. The chronic TMD cases were moderately symptomatic, and they had a few chronic overlapping pain conditions. And then in 3, which they termed global symptoms, these folks were found to have abnormal psychosocial, sensory, and autonomic profiles. There were much more women in this group than men. They tended to be older. They had many chronic TMD cases that fell into cluster 3. The TMD cases that were there were highly symptomatic. They had many different overlapping pain conditions and many negative life events or adverse early events. So all in all, those studies combined with, a growing amount of literature have shown that as the number of pain diagnoses or body sites of pain that a person has, there's a vicious cycle that ensues. Starts at the top of this figure with worsening of localized and systemic symptoms. So not just if you have interstitial cystitis, not just worsening of IC pain, but pain that you may have in other areas of the body. The more conditions one person has, or the more sites of body pain they have, we know that they are less likely to respond to treatment. So there's a decreased treatment effectiveness. They have reduced health and psychosocial outcomes, increased levels of disability, increased both personal and societal cost, and markedly diminished quality of life. So this really highlights our rationalization and justification for why there needs to be a specific focus on advancing scientific and other initiatives for chronic overlapping pain conditions. As we're all familiar as well, there's another vicious cycle that comes into play with non-pain conditions that affect people with overlapping disorders, which includes sleep. So we know that having pain makes sleeping difficult, and that poor sleep or sleep disorders negatively impact one's chronic pain, mood, and energy levels. That ties into your mood, right? So pain and poor sleep negatively affect your mood, and that worsens your ability to cope. Which also ends up affecting your energy and fatigue levels. So pain combined with poor sleep and mood changes tends to drain your energy and leads to fatigue. And then obviously that impacts your level of activity and your participation in daily life activities. So the pain, poor sleep, mood changes, fatigue, and decreased activity leads to worsening pain, and the cycle continues. So this really highlights the importance that we can't just seek medical care for the quote unquote pain that someone's experiencing along with their condition, but all of these factors are really important components that need to be identified and addressed in a clinical exam, and they also need to be part of a treatment algorithm or treatment plan if you're really going to improve the lives of people who have chronic overlapping pain conditions. So what do people who have these conditions experience? We've done a lot of work in people who have chronic overlapping pain conditions, and this is a typical cycle from the onset of pain. When you start at the top of the figure, a lot of times people are confused about why their pain has started and what the onset is involved in. You know, do they have some sort of disorder, disease, cancer, infection, something that's causing the pain? They tend to visit numerous doctors and have highlighted this idea that there's the search for causal attributions that doesn't necessarily lead to any specific information or specific cause for their pain. A lot of times people are trying to self-manage with various strategies that provide some relief, some moderate, some low, some none. That they oftentimes experience numerous barriers in seeking medical care and help for their condition and what they're experiencing, and also a delay in treatment for their IC as well as other pain conditions. And then obviously that's all another kind of vicious cycle that ends with a lot of consequences, not just on how you physically feel, but your emotional health, sexual health, relationships, work, pretty much every area of your life. And then for people who have chronic overlapping pain conditions, because our healthcare system is so fragmented by different medical specialists that don't necessarily work together or communicate with one another, a lot of people with COPEs have reported, you know, that as they develop additional conditions, it's further complicated because they're seeking care from different medical specialists. So you may be seeing a urologist for bladder pain. You may be going to a rheumatologist for fibromyalgia symptoms. You may be seeing a gynecologist for vulvodynia. And patients report receiving multiple treatment recommendations from different specialists, again, with very little communication between them. And there may be a great deal of disagreement between the providers in terms of what types of treatments one should pursue. There typically is a lack of a primary clinician to coordinate medical care, and many people have talked about, you know, the enormous amount of stigma and invalidation that they experience, which can lead to poor health and quality of life outcomes. So we know that there's a lot of treatment approaches for chronic pain and for chronic overlapping pain conditions. Where we're lacking is in data to say, you know, who is going to benefit from which treatment at what time, at what risk, and at what cost. But this is just a general slide that kind of breaks out the different types of treatments that are available for chronic pain in general and chronic overlapping pain conditions in specific that range from less invasive to more invasive. They can include, you know, drug, pharmaceutical options, surgical options, electrical options like TENS, And then also in the pink category, biopsychosocial treatments that are non-pharmacologic, like physical therapy, self-management, cognitive behavioral therapy, or integrative or complementary approaches. But the idea is that regardless of whatever type of treatment a patient is utilizing, their care should be patient-centered, right? And so this definition of patient-centered care has been around since like the mid-70s. It just is kind of recently starting to get an uptick in the medical system, but the definition of patient-centered care is one that provides care that's respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patients' values guide all clinical decisions. So this is a team-based approach when you're working with your provider for him or her to understand what's important to you, what your needs are and values are, and that is guiding the treatment decisions and the clinical decisions that you're making together. So this is just a slide that shows the principles of patient-centered care. There's 8 different principles associated with it. Starting at the top, again, there's a respect for patients' preferences. There's a coordination and integration of medical care. There's information and education that's given and bi-directional with your clinician. It should address your physical comfort, but also provide emotional support. If you choose, it should also include the involvement of family and friends in your healthcare team, if that's what you would like to do and you would like them involved. The continuity and transition piece doesn't really apply to, it applies more to hospital-based care when you're moving out of a hospital-based system into transitioning into care by a primary care or other type of specialist. But it is one of the components of patient-centered care. And then lastly, that we all have access to quality care. It also includes the components of shared decision-making, and this is just one shared decision-making figure from AHRQ called the SHARE approach. And this is taught to clinicians who want to work with their patients in terms of partnering to make better informed decisions together, rather than a clinician saying, okay, here's the treatment that you're going to do, without providing any type of explanation of that or discussion with their patient. So the first thing that clinicians are advised is to seek the patient's participation in discussing and making decisions about treatment choices and healthcare plan. Secondly, to help the patient explore and compare different treatment options together. Third, to assess a patient's values and preferences, which we've talked about already. To fourthly, reach a joint decision with the patient about what treatments or treatment approaches they would like to try. And then fifth, to evaluate the patient's decision together. So again, this is just one shared decision-making model, but it is an important component of patient-centered care and one that we should all have access to, although many of us do not. Another component of patient-centered care is functional goal setting. So a lot of times people who have chronic overlapping pain conditions or chronic pain in general will say, well, I go to the doctor and they just say, how bad is your pain on a scale of 0 to 10? But we never talk about what are my goals with treatment? What things would I like to get back to doing? It's just, how bad is it? You know, how bad has it been over the last week? How bad has it been over the last 3 months? And as we know, pain is so variable and changes hour to hour, day to day, week to week. That's really hard for a lot of people to assess. And there are so many other important domains like sleep, mood, function, cognitive impairment that patients have reported are much more important to them, and that there are goals that they would like to set. So functional goal setting is a part of patient-centered care. And basically what this is for a person to identify a meaningful activity that they cannot perform as a result of their chronic pain, but they'd like to be able to accomplish as a result of pain management, right? And research has demonstrated that goal setting helps increase progress towards mutually agreed upon goals between clinicians and patients. It helps foster adherence to the clinician's recommendations. It helps to create successful individualized treatment plans that are specific to you and what matters to you, and that it also does improve communication between patients and clinicians. So how does this work? The first step is that you work together to address faulty beliefs. So for example, let's say your goal is to, you haven't been able to exercise, and so you want to get back to being able to exercise again, and you would start by walking. And so one faulty belief may be that, if I do any type of walking, it's going to make my pain condition worse. That's just one example of many beliefs that people may have around pain, or depending on whatever their goal may be, but that's the first step in this process. The second step would be to select a focus area, and I'm going to go through an example on the next slide. And then to use a SMART system to help develop a plan. Again, I'm going to go through an example to break that goal down, and then to identify obstacles beforehand and solutions so that you can stay on track. So here's just one example around, as I just mentioned, exercise. So let's say a meaningful long-term goal to that person would be to be able to walk for 20 minutes, 5 days a week. So you're obviously on day one, if you haven't been exercising or walking in a long time, you're not going to start with walking 20 minutes on day one and doing it 5 days a week. So the first small goal may be for weeks 1 to 3 to walk 7 minutes, 3 days a week. And then maybe you'll progress up into weeks 4 to 6 to walk 14 minutes, 4 days a week. And then eventually goal 3 for weeks 7 to 9 to walk 20 minutes, 5 days a week. And so those possible obstacles could be bad weather. What happens if the weather's bad? It's raining, snowing, I can't get out, or I feel unmotivated to do this. And then some steps to address potential obstacles and stay on track would be to join a gym, or plan to walk at the mall, or identify other indoor public spaces and when the weather is bad. And then for accountability and motivation, to get a walking partner for company, encouragement, and accountability. And again, this is just one very specific example, but other people want to be able to get back on the floor and to be able to play with their grandchildren for 10 or 15 minutes a day. Other people want to engage in social activities. And so there's a lot of different types of functional goals that people can set, but it has been known and proven to, as we went through in the slide before, help identify a positive direction for treatment, and to focus on the positive and what you're accomplishing rather than how bad is it from visit to visit. And so I just wanted to provide a few resources as well that the CPRA has developed for people with chronic overlapping pain conditions. So we have a self-help guidebook, and that's available on our website for free. You can download it or read it. We do have a short brochure on overlapping conditions. We publish an electronic newsletter called Research Advances that provides abstracts of recently published studies on all areas of chronic overlapping pain condition science, and you can sign up for that on our website as well. We also have a white paper that we're revising in the next year as well, because it has been 10 years since we originally published that. And then we have a wealth of resources on our website as well. So with that, I will end and be able to take a few questions.
Thanks so much, Chris. Okay, we have a couple comments in the chat. We have one person that said, I have IC. I've tried many remedies, have not had much success. I have pain that has increased, looking for more treatment options to feel better.
Yeah, this is very common. I mean, as I mentioned on the one slide, we have so many different treatments that are available for chronic pain and for chronic overlapping pain conditions in specific. And what I can say from my own personal experience is that it took quite a bit of time experimenting with a lot of different types of medications and non-drug therapies like physical therapy, massage, chiropractic, so on and so forth, to find what works for me. Ultimately, because we have not had a lot of research on chronic overlapping pain conditions and chronic pain in general over the years, I find that's one of the most frustrating parts of having one or more of these conditions and trying to identify treatment, which is you could have the best clinician in the world. I work with, the forefront experts, international experts, and none of them could do an exam on me and do an exam on you and say, okay, well, you should try treatment 1, 7, and 9, and you should try treatment 2, 4, and 6, right? Like we just do not have that type of data, which is one reason why the CPRA focuses so much on advocacy for research, because until we have better data on what works for whom, and can put those treatment algorithms together, it still is going to be a trial and error process pretty much for everyone who's undergoing that. And I understand the frustration with that. I guess on an encouraging note, I would say that it is possible to find, a combination of treatments that does help you. For me, it took a few years, but I did get there. My pain is not completely gone, but it is manageable. Some days worse than others. But I do at least have a toolkit or a toolbox of things that I can go to on different days to help myself feel better. So I would encourage you to look at our guide. We do have a section in there on different treatments that are available. So you may see some that you have not tried. And I would just encourage you, hopefully you have a good clinician and you can speak with him or her about what options may work for you and to develop a plan for trying to target, those one by one to hopefully identify one that or more that's helpful for you.
Thanks for that, Chris. The next comment was agreed with the above comment. And then they wrote, thank you for this. At times I can't believe how many things are wrong with me. And I think, am I the only one? I found out that I need to really manage my own care.
Yeah, and I think, I can certainly say that this is a common thing that we hear all the time. And because our healthcare system is so fragmented, we're seeing one clinician for this body part and another clinician for another body part, and each one are not asking about the other or any other kind of holistic effects. And having a comprehensive approach. This is essentially how the whole idea of chronic overlapping pain conditions came together. Like when we first started talking about the need for advocating for research in this area, we started asking clinicians, okay, out of your patients, like how many of them have just one isolated pain condition versus multiple? And many of them would tell you, well, the majority just have one, and the rest, there's this small group, maybe 20 or 25%, that seem to have this whole mishmash of symptoms, fatigue and sleep issues and multiple areas of body pain, cognitive impairment. But when we actually started doing research through the OPERA study, through the MAP and other research studies, it actually is the opposite, and especially in women, that it's more likely, that 20% group are the group that have one isolated pain condition, like a knee osteoarthritis or something like that, whereas women are much more likely to have multiple areas of body pain and non-pain comorbidities. But because we are so isolated by condition, even today, our organization deals with a certain number of conditions. The ICA deals with interstitial cystitis. Another organization deals with migraine. Another one deals, like we are all very, and we're doing good work individually, and we're also trying to network and collaborate to make people more aware of the other resources that are available within our healthcare system. Unfortunately, we're still in this place where we're seeing one person for one thing and another person for another thing without coordination. And that can lead to this idea that you express that, am I the only one that seems to have all of these things? And I can assure you that you are definitely not the only one. And you're not even in a small group, you're in a very large group. There just has not been a lot of work and awareness about this, even though it is starting to uptick for sure.
Thanks. Next question. Who is the best type of doctor to see for overlapping pain conditions?
Oh, that's a really hard question to answer because we don't have quote unquote specialists for overlapping pain conditions. Um, there are some clinicians who have started out specializing in one condition, like fibromyalgia or interstitial cystitis or irritable bladder, or I'm sorry, irritable bowel, who have kind of expanded their practice and they now see other people. They treat that condition, so they may, in interstitial cystitis, it may be a urologist, but they've done additional training in pain management and other body systems to address different types of overlapping pain conditions. There is not one particular type of specialist that I can say, if you have this, this is where you go. Certainly, neurologists and physical medicine and rehabilitation, other people that specialize in kind of general chronic pain management are typically more aware of chronic overlapping pain conditions and more aware of this idea that people can have multi-site body pain that's connected and that needs to be addressed and connected together. So I wish I had a better answer for you. It's, as I just mentioned, two different categories. So one kind of neurology, physical medicine, rehabilitation, and other specialties that deal with chronic pain in general, pain management specialists, and then also that category of people that have specialized in one of these conditions, but have also expanded their practice to address multiple.
Thanks, Chris. Next comment is patients so often experience doctors who say it's all in the mind, somatization, catastrophization. That's very depressing for patients.
It is, for sure. I mean, in the 30 years that I've been doing this, we've come a long way in this area, and certainly research has helped to legitimize the biology, the underlying neurobiology of these conditions. And so there's a lot less of this, but there still is a ton of stigma and bias around pain and a lack of understanding of what chronic pain is and is not. And a lot of patient blaming, when there isn't a quote unquote underlying cause that's very obvious that can be found. So I totally understand that there has been a recent movement from clinicians, researchers, and patients to rename some of these terms that you mentioned because they are oftentimes very derogatory, make people feel like they're being blamed or they're doing something wrong to cause their condition, when really what we're talking about with somatization is an underlying biologic phenomenon. It's not something that you're coming up with in your mind. With that said, we all do also know that there is, not just with chronic pain, but any medical condition, any chronic medical condition, there is a tie between your level of social support, whether you have positive coping strategies and how you think about your condition and the impact of your condition and the outlook of your condition, that does all play a role. It's not blaming, it's not the cause, but it's just a combined thing. And that in order to be well, right, we not just need to be physically well in terms of our pain symptoms, but we also want to do everything that we can to be as psychologically and emotionally well as possible, which, like I just said, working on positive coping strategies, having good social support, being aware of negative thought processes and how to deal with those. Those are a component of dealing with any chronic medical condition, and there's nothing different about chronic pain in that respect, other than the fact that it's just important to identify and address. But it certainly can be very depressing and very challenging for people when they're trying to seek help for what they experience and they feel like they're being blamed for it or like they're doing something wrong to cause it. So thankfully that is changing and science is helping us change that. But we still do have a ways to go for sure.
Thanks for that. I did see that, Marjorie, you had your hand up. Did you want to ask a question, or I see it's down now, so I don't want to put you on the spot, but maybe not. Okay, I'm going to go over to our next.
Can you hear me?
Oh, there you are. Yes,
I guess I
please.
unmuted. I'm sorry.
No, you're fine. We're fine. Please
Yes.
go ahead and ask.
Naturally, these chronic conditions, and I have several. I am been trying for 7 years to cope with the IC and vulvodynia. and I've just been diagnosed with RA, which is minimal right now. I'm not on medication for it, but I am experiencing some symptoms of it. I do have some chronic conditions, and these have been developing over several years. Depression has been a big one to conquer. It's been long going now. I've been working on it for 7 years. I've tried many medications that have bothered my interstitial cystitis. Um, I'm wondering what type of psychiatry or that I need. I've been to several psychologists through the years. These past 7 years have been very rough for me. I'm at a point now where I know that I need to do something concrete. What would be your suggestion? And are there people that deal with these various overlapping conditions that could help me in the
Yes,
area of psychiatry?
yeah, there definitely are psychiatrists, psychologists, counselors that specialize in both chronic disease management and chronic pain management in specific. And so while the general psychological treatments, like I'm sure you've heard of cognitive behavioral therapy and pain reprocessing, there's a lot of kind of general psychological treatments that could be used across conditions. These treatments have been specialized for chronic pain, and in some cases specifically for the various chronic overlapping pain conditions that you may experience. So there definitely are groups of people out there in the psychiatric field that are, specialize in this area and can be helpful in that. We do, again, in the patient guide that I mentioned on the resources page, we do have a section on those types of therapies as well. Although it's not exhaustive, it does give you some idea of some of the therapies that are available. But I do, again, it's a significant overlap, and I've struggled myself with depression over the years. It's kind of, I would say it'd probably be abnormal for somebody to experience all that we experience with chronic overlapping pain conditions and not experience some level of depression,
Mhm.
just because of the enormous impact that it has on pretty much all aspects of your life. But it is something that can help, if you address it, can help improve your overall quality of life and your ability to cope and to function, to feel better, and to live a meaningful life.
Okay. Okay. Thank you.
Sure.
Thanks, Marjorie. Thanks, Chris. The next question is, do you have experience in the idea of pain being an overactive neurological system and trying to quiet the brain down? Do you believe this is possibly at play in pain management?
Yeah, so if I think I understand the question correctly, what we've learned, one of the major advances that I see in the last 10 plus years has been in brain imaging. So, 20 years ago, the idea was that if you have pain in X body part, right, let's just say the bladder for IC, that there has to be something wrong in your bladder that's causing this pain to be generated and this pain message going to your brain. Now we understand from MRI research, brain imaging research, that necessarily doesn't have to be the case. That people who go on, and that was in the figure that I mentioned around genetic susceptibility, people who go on to develop chronic overlapping pain conditions, their brain structure and function within the central nervous system is different than people who do not. So there has been a lot of research showing that both the structure of the brain and the way that different areas of the brain communicate with one another is very different in people like us who develop, chronic pain in general or multiple chronic pain conditions. And so this is essentially what we would call a hypersensitized nervous system or neurologic system, as you mentioned in your question, which basically means that our central nervous system doesn't respond the way other people's does. And there's a really interesting study that was done at Northwestern where they followed people who came in with whiplash injuries. So they had all been in minor vehicle accidents, all had the same type of whiplash injury, and then they did imaging on all of them, and they followed patients to find out who will have the normal amount of acute pain and then receive treatment and recover and go on and not to have any type of chronic pain. And then they also followed the group that had the same treatment, same acute pain, but they went on to develop chronic pain long term. And what they showed is that the imaging, the brain structure and function of those two groups is very, very different. So I'm sure you've heard, like in the fibromyalgia space, where our kind of like our sensitivity dial is tuned up, where our central nervous system is more heightened, it's more sensitive to pain symptom or severity. It could be light, it can be odor, it can be sounds, those types of things. So it essentially points to the fact that our nervous systems do not function the way that other people's do who don't go on to develop chronic pain. That has been, in my opinion, one of the most transformative types of findings and research that we've shown over the last decade or more. One, to legitimize, as Jane said earlier about the catastrophization and somatization, and like we're being blamed for causing our problems when in reality, our central nervous systems don't function the way that other people's do, right? So that has gone a long way to legitimize the underlying biology of chronic pain and these conditions, and to provide a better understanding as to how we need to treat them. So if you do have, for example, in the MAP study, the population of people who had IC and other comorbid conditions, the tie between all of those is your central nervous system. So it points to the fact that you may need treatments that are more targeted towards the central nervous system and not necessarily the bladder specifically. It doesn't mean that treatments targeted at the bladder won't be effective in your case, or they may not help. It just means that it helps to identify what may be coming from the periphery, what may be coming from the central nervous system, and the idea that we need to tackle probably both of them to be more effective in treatment.
Thanks. We have another comment. It's, I have mentioned my sleep disorder to every clinic and each one ignores it. Why? And should I try my own treatment, like pills?
Yeah, that's really frustrating because we know just from general research in healthy people that when you deprive people of sleep for 24 hours, that their bodies become more sensitive, right? So this is just like normal people who have no pain conditions, no anything. So we know already just in every single human being that sleep deprivation leads to pain sensitivity, and that's not a good thing. And we obviously have a wealth of research in people with chronic pain and chronic overlapping pain conditions as to how important sleep is in that vicious cycle that I presented in one of the slides. And that's discouraging, that you're mentioning that to clinicians and they pretty much ignore it, because if you don't address all of the components that are affecting your individual condition, you're likely not going to be receiving the max amount of treatment benefit, right? So you may be doing one treatment to target your IC pain, and maybe you're doing another treatment if you have mood disorders or depression. But if you have a sleep disorder, or if you're experiencing sleep difficulties, you also need a treatment to identify that. I would encourage you to seek out help from a specialist, a sleep specialist. There is a specialty for sleep disorders. There is a lot of information online about good sleep hygiene. A lot of us don't have it. We don't practice it. In terms of like how much sleep we should be getting at night, what our surroundings should be like, what things we should or shouldn't be doing before we try to go to sleep at night, what should we do if we wake up in the middle of the night. There's a lot of self-help things that you can do as well. I'm not a medical professional, so I can't or won't recommend whether you should do a pill or something else. It really depends on your individual condition. And the severity of whether you're just experiencing sleep issues or you have actual diagnosable sleep disorder. But I definitely would encourage you, if you can, to read about good sleep hygiene, try to practice those, as well as seek out specialist care from a sleep disorder clinic, so that you know exactly what you're dealing with and you can include that in your treatment plan.
Great. Thank you so much, Chris. We are so grateful that you were here with us today. Today's session was so very informative. We hope you all enjoyed this webinar and learned something new. If you found this event to be of value, please consider joining us for future webinars and share these opportunities with your community. Mark your calendar for August 8th for our next webinar titled PBS IC in the context of chronic regional pelvic and genital pain. Our speaker will be Dr. Robert Eckenberg. A link has been posted in the chat. We also have an announcement. Did you know that the ICA is turning 40 this year? It's significant because the ICA has been the sole nonprofit organization dedicated to ICBPS for 4 decades. So please be sure to keep an eye on your inbox for ICA emails, follow us on social, and participate in our 40th anniversary activities. Thank you so much for being part of our mission to improve the lives of people affected by ICBPS. And thank you for joining us today. I hope everyone has a good day. Thanks, Chris.
Thank you.
Thanks for having me.
Thank you very much.
Thanks, everyone.